Welcome. Thank you all for joining me on this beautiful Saturday afternoon. Today is the last day of the Canadian Infertility Awareness Week, and I wanted to come on to do an IG Live for you and answer some questions about trying to conceive. And I think in the last year or so, there's been a lot of pressure put into excessive pressure, I should say, onto fertility patients with the pandemic, and there's a lot of fear around clinics closing and things like that. So I just wanted to let you all know that, fertility services are deemed an essential service, and the clinics are doing an excellent job at following protocols, PPE, rapid testing, keeping our patients safe. So I really do applaud the staff, the nurses, the lab staff, everybody, the admin, for keeping our clinics open and keeping you in cycle and having treatment available for you. So my name is Dr. Tracy Malone. I am a naturopathic doctor. I'm one of the co-founders of Conceive Health. Conceive Health is a dedicated preconception clinic. We work with patients that are trying to conceive or interested in conceiving. We also work with patients that are using ART, or artificial reproductive technology, IVF and IUI, to conceive. So we treat a variety of different patients across the spectrum of just thinking about trying, actively trying, trying and persisting, and then people that are in active treatment, donor, and surrogacy. So that's my kind of scope. And my clinic is located down in Toronto on Bay Street, and we are partnered with Trio Fertility, and we are actually a very unique clinical model. We're embedded inside of the IVF clinic, so my clinic lives inside the IVF clinic, and we have this really fabulous integrative clinical relationship with our physicians. So down at Trio, I think we have about 13 REIs, or reproductive endocrinologists, in infertility, and we actually share charts with our doctors so that there's an ease of transmission of information and of treatment protocols, so that everything's transparent and everything is safe. So today, I just wanted to let all of you patients know that we do see you. We see you trying despite the excessive pressures that the pandemic has added to your journey. And today I just wanted to come on here and answer your questions, because I know that there's a lot of questions floating around the table about preconception, about trying to conceive. And I just wanted to come on here, and we have already pre-fed a lot of questions. So some questions are pre-populated, and I will actually answer live questions as well. If anybody has asked me anything, today's your chance, okay? So the first thing I think we should demonstrate is that, our sort of motto at Conceive Health is the 100 days, to preconception. We always say 100 days, your health is their future. And the reason we say that is that the 100 days or 3-month window prior to conception is an opportunity for us to change the health of the gametes, or the egg and the sperm. So women are born with all of the eggs we'll ever have. And what happens each cycle is that a cohort of follicles come from the ovaries. We call them sleeper or primordial follicles. And these follicles begin to mature. And that's called folliculogenesis. And it takes about 100 days, about 90 days, we round it to 100 so people can remember, to mature those primary follicles into antral follicles that we see on your cycle day 3 ultrasounds. And it's in that 100-day window that the environment will impact how those eggs mature, and then how viable they'll be later on at the cycle, where it's their opportunity to be ovulated. So the 100-day preconception for the egg really is in place while that follicle matures. So things like nutrition, chemicals, sleep, stress, nutraceuticals or supplements, antioxidants, that's where these things can be really effective when we're looking forward to conceiving, or especially if we're looking forward to doing any type of fertility treatments. In a man, it's slightly different. We can't forget our guys. Fertility issues in couples, almost 50% of the time are male factor. And I think that conversation needs to be, the volume needs to be turned up on that one. More often than not, I do see at least one variable within a male fertility assessment, typically in the semen analysis, where we could probably improve on count or motility and morphology. So the big difference between eggs and sperm is that sperm are actually created entirely in the present environment. So as I was talking to some patients last week, I was saying that, the sperm that we have here today, everybody will be new by Canada Day, right? So that's that 100-day period of time where those sperms are regenerated, and so we'll have a whole new cohort 100 days from now. Now, sperm are the most vulnerable cell probably because they are the smallest and they're exquisitely sensitive to their environment. That could be chemicals in the environment, anything from social toxins like alcohol, cigarettes, cannabis, to occupational exposure, solvents, paints, chemicals, that type of thing in the work environment. And then to our lifestyle, right? So, we do see lifestyle factors, exercise, obesity having a massive impact on male factor fertility as well. So when you put all of these things together, it's very, very clear why we would consider treating a couple together for that 3-month period prior to conception, because that's going to result in healthier sperm and eggs. And when we put that together, we're going to have a healthier embryo and a healthier baby. So that's kind of what we do in a nutshell. So I'm going to get straight to it and start answering some of your questions, okay? So I'm just going to lean over, and this is my first IG Live on my own, so just bear with me, ladies. Okay, so let's see. So here's a question. So if my periods are getting shorter and lighter, but all the tests are good and we are ovulating, does it affect my fertility? That's a really good question, because these are things that you can notice at home. If you notice that your cycle is either shorter or longer, especially shorter, typically it means that you are ovulating sooner in that luteal phase, or that first phase of your cycle. So that, in combination with her saying that her cycles are also lighter, that also makes me think that perhaps her hormone levels are a bit more blunted, because the endometrial lining wouldn't be thickening as much as it might if they were higher. So in this case, I would say that, lots of things can influence length and duration of menstrual cycles. Stress for sure is one of the big ones. A high level of exercise, if it's over the top, can also cause that. But if this was one of my patients, the first thing I would want to do would be do a day 3 assessment on her. So usually we call that the day 3 big 5, right? So we want to test FSH, a follicle stimulating hormone. And if that one is above a 10, it gives us a bit of context that there's an issue with ovulation and maybe how much time we have before we can have a baby. We're looking at LH, which is luteinizing hormone, and that should be nice and low on cycle day 3. We're looking at estrogen levels. Estrogen levels on cycle day 3 should range somewhere between 100 and say 250. Progesterone should be low in that part of the cycle, and normally I'll run a TSH test as well. So the first thing I would say, if your periods are getting shorter and lighter, would be ask your family doctor or ask your fertility doctor or your naturopathic doctor to run some blood tests that are cycle day specific on you, get a little bit of context on your fertility potential and egg reserve, right? Another test you could consider doing is called AMH. AMH stands for anti-Müllerian hormone, and it, in combination with the hormones I just mentioned, are typically part of an initial fertility assessment, and would flag that patient and let her know if there was potentially something awry. Okay. You guys doing okay? I can't hear you. I'm just talking to myself, so I'm just going to keep going until Katie tells me otherwise. All right. So here's question number 2. After 4 years of infertility, IVF is starting in 2 months. What can I do to prepare my mind and body? So IVF is starting in 2 months. Typically with IVF, you would go on to a birth control pill or a prime before you would start injectables. So technically, she probably has close to 3 months before she's going to retrieve. So my recommendation for somebody who has had 4 years of infertility, which is quite a long journey for her. She's been trying for 4 years and hasn't had a conception or potentially hasn't had a pregnancy that's made it out of the first trimester. I would recommend that this person would see a specialist to help her prepare for her IVF treatment. And certainly I'd be looking at using egg quality agents and such as coenzyme Q10, essential fatty acids, glutathione, or N-acetylcysteine in order to prepare her for the best cycle outcome possible. So for that patient, I would absolutely recommend a personalized consultation with a fertility-minded naturopathic doctor in order to prepare her body and her eggs for her IVF cycle. And don't forget about the guys. They're half the DNA of the baby, right? And because they turn over every 2 to 3 months, you can see a massive change in your partner's semen analysis in just 2 to 3 months. So bring him along for part of the conversation. Let's just see here. Question, this is appropriate because it's springtime. So question number 3 is how to manage seasonal allergies naturally while in IVF treatment. So this is a tricky one because we really don't want patients using anticholinergic agents that would shrink back membranes that are commonly used in allergies. It can really interrupt the hydration potentials of the cells, both men and women. So one of the things, there's a few things that we could use that's safe. So the things I'm looking for, they're safe, they do not interact with IVF or fertility medications, and there's no known side effects that would impact the outcome of their treatment. So vitamin C is the first and foremost one that I think of. You can really stabilize mast cells and the severity of seasonal allergies with about 2,000 milligrams of vitamin C. I like Ester C. It's a calcium-bound vitamin C, stays in the white blood cell longer. And it's good for your eggs, right? Good for your eggs, good for your sperm. Another one that I think of is quercetin. So quercetin is a bioflavonoid. It actually comes from the inside white bits of an orange peel. You can also find it in garlic and onions. And it also really has a great impact on stabilizing those mast cells. And so those would be the 2 key ones that I would potentially use in a seasonal allergy treatment. And the third one is nettle tea. Now that's super old school. I think one of my old school Romanian botanical professors taught me that one, Hannah Weidenfeld, actually. And so you make a tea out of the fresh leaf of the nettle plant, stinging nettle, urticaria, and it is highly anti-inflammatory and anti-allergenic, and it's also very nutritive. It has a ton of calcium and aqueous iron. Okay, let's see. This is a good one. So, can you talk about how to plan sex in the fertile window, especially when you surge? So this is key. This is super key for patients that are trying to conceive at home in the pandemic. And so one of the first things I would say to patients is you got to become familiar with your cycle. I attended a conference not too long ago that kind of reviewed all of the apps that are on the World Wide Web to track your cycle. There's like hundreds of them, thousands of them, I would say. And so all of these apps really sort of underlying assume that you ovulate on cycle day 14, which is really actually not always the case. And so I think that one of the most important things that you can do is to track when you have your ovulation surge. So women can ovulate as early as day 8 or as late as day 20. So if we're not hitting your window, that's problem number one. So oftentimes when a woman has, say, a 28 to 30 day cycle, I would ask her to purchase ovulation predictor kits, or they call them OPK kits. And what these are they're little, I should have some with me, they're little pee sticks that you would urinate on. I would tell my patient with an average 28 to 30 day cycle to start on cycle day probably 8 or 9. Okay, so cycle day 1 is the first day you get your period. So on cycle day 8 or 9, I would ask her to start urinating on these test strips once a day. Okay, and usually I would ask her to not use her first pee of the day, first morning void, because that's hormone from yesterday. So I would say to use an ovulation predictor kit, you want to do second pee or beyond in the day, and start testing around cycle day 8 or 9. And what you're looking for is a test line that is as dark as the control line. So some of them have double test lines, and you're looking for that to come up bright and dark, just as dark as the control line. And that would indicate that your LH hormone, your luteinizing hormone that comes from your pituitary gland, has surged. So it usually goes from resting around 5, and it'll surge up to 30 or 40 when you release your egg. And so instead of guessing, test, right? Use these OPK kits to test. And I'll usually get my patients to do this for at least a month or two, and write down what cycle day they're commonly seeing that surge. And it is important to talk about the fact that you will see a faint line start to appear as you're about to ovulate, right? And that's the LH sort of incrementally climbing in some women. But your ovulation date is when you get that big dark surge, okay, that is as dark as the control line, or sometimes it's just a happy face. You can kind of confirm that to yourself and sort of look for physical signs of ovulation, which would primarily include cervical mucus. So we're looking for that egg white, that clear egg white cervical mucus that would be, present in more copious amounts. We call it the slip and slide, right? It's like, personal lubricant almost. And so that type of mucus should appear when she is close to and surrounding ovulation. So that's another sign that you can check to see. Some women notice that their libido actually picks up surrounding ovulation, and some women can actually feel ovulation. That's called Mittelschmidt's, and that's a tiny little pain or twinge that she might feel when she actually releases the egg. The second thing that you can do to track your cycle is to use this nifty little test. I love it. One of my naturopathic doctors in Kitchener was doing a lot of research on this one. And so the test is called PROOV, P-R-O-O-V. And the PROOV test is a great little urinary test kit. And you take that test on day 21, right? And so what it's testing for is progesterone. So if a woman has ovulated, her progesterone levels should incrementally rise after ovulation and go from 4 or 5 on cycle day 3 to they should be above 30 on cycle day 21 if she has ovulated on cycle day 14. So my suggestion would be that when you see your OPK kit, your ovulation predictor kit, go off, and you see your cervical mucus, that's kind of signaling that you've ovulated. And then 5 days later, you can go ahead and do the PROOV test, which will prove that you've ovulated by showing you that your progesterone level is above 30. Now, some women can ovulate and their progesterone level is low, and we call that a luteal phase deficit, or low progesterone level in the second half of your cycle. And so if the proof test does not go off, it's possible that you still ovulated, but that you do potentially is signaling that you have lower end progesterone in that luteal phase. And that's something we can treat at the clinic by giving you vaginal or oral progesterone. So what I just described there is kind of, at-home cycle monitoring, right? And so you can do it with these little sticks, or there's a nifty little device out that I've been kind of teaching my patients how to use called Mira. And Mira tests all of these hormones, and it has a little device, and it actually gives you a quantitative level, so the numerical value of each one of these hormones, which just provides like another depth or layer of information for us. I think that can be sometimes difficult for the patient to interpret on their own. So a lot of times at the end of the cycle, I will go through that cycle monitoring with the patient if they're monitoring at home. So hopefully that answers that question. And so really the question was how to plan sex in the fertile window. So healthy sperm can survive in the vaginal canal for up to 5 days. So I always ask my patients to, standard deviation 2 to 3 days on either side. So you're going to want to have sex for about 4 to 5 days surrounding your ovulation. 2 days before, 2 days after. Okay, let's see. Question number 4. Natural remedies to relieve bloating and pain following an egg retrieval and or hormonal meds. Yes, this is a question that I get asked all the time. Because if you have ever set foot into a fertility clinic, you know that when patients are either taking or injecting hormones, that there is a ton of water weight that is gained. It really messes with your electrolytes. And, after an egg retrieval, her hormones have skyrocketed. She's had a minor surgery, and there's actually a good amount of tissue disruption as well. So one of the things I do suggest is to stay hydrated. Egg retrieval time is not a time to get dehydrated. It'll make it worse. I think it is important as well to add electrolytes to the fluid. So you're going to be trying to hit like at least 2 liters of water with electrolytes in them daily. And I will actually often recommend to my patients this particular green smoothie. And the reason why it's a green smoothie is because there are certain vegetables, brassica family vegetables, broccoli, kale, cauliflower, mustard greens. These all contain a phytochemical called indole-3-carbinol, and it actually helps your body metabolize and conjugate that high estrogen level and sort of press it through your system, detoxify your system. It's full of, electrolytes, potassium and magnesium, and it's got a ton of phytochemicals that are quite good. So I'll usually recommend those to my patients. We can totally put that recipe up onto the website. I have a nifty little pictorial recipe for it. It actually came out of the book, Oh, She Glows. So I love that cookbook, and there is a really good smoothie section in her first book, and one of them is called The Reset, and that's it. The smoothie is actually based after that recipe from Oh, She Glows, and it is delicious. Let's see. So specifics, I have a couple questions here that are similar. So specific supplements and vitamins for endometriosis before transfer, and specific supplements for endometriosis before IVF stimulation. So those are similar. So endometriosis is a reproductive condition or that affects a lot of women. I'm not sure the exact statistic, but it's pretty high. I think it's like 1 in 8. Endometriosis is graded on a level of, say, 1 to 4. It does require a laparoscopic surgery investigation to be properly diagnosed, which makes it kind of evasive to diagnose. And so some women can go their whole lives without a diagnosis. But clearly she often knows that she has it because endometriosis can be quite painful. So endometriosis is when the cells that line the uterus, the endometrium, have migrated outside of the uterus and have seated themselves inside of the pelvic cavity. The grading really represents the distribution, severity, concentration of these particular lesions. And what makes it so painful is that when these cells respond to hormones, and so they will grow and then shed in tune with your menstrual cycle. But because they're not contained inside the uterus, those endometriosis cells, or endometrial cysts, they call them, will actually bleed directly into the pelvic cavity, causing a huge amount of inflammation, oxidative stress, and pain. She's in pain. So I kind of subclassify endo as a chronic pain condition. It is also subclassified as a autoimmune condition. So normally these women do have higher levels of inflammation. When you look at sort of linear trends in women that have endometriosis, they also have issues with estrogen metabolism and detoxification. So some of the research studies that are safe before transfer for endometriosis are some of the heaviest research lies in cleaned high-dose essential fatty acids. So I definitely consider giving her a high dose of omega-3, whether that's a fish oil or an algae oil. And you want that to be EPA dominant because that's going to really downregulate the inflammation. Endometriosis patients do really, really well on a product or on a plant pigment called resveratrol. It really does downregulate the inflammatory nature of the endometrial lesions and the severity. Definitely, I see clinically a correlationship with endometriosis and disrupted what we would call microbiome. So your microbiome is the bacteria that you would carry either in your GI tract or in your urogenital tract. And the bacteria can be really sensitive to hormones and pH, and can, if there's an overgrowth in a particular type of bacteria, can also lead to a lot of inflammation and affect estrogen metabolism. And around we go. So it is important for endometriosis patients to have a good sort of gastrointestinal microbiome. So I usually put them on a probiotic. They tend to do better on really high fiber, plant-based diets. So they tend to do better when we take red meat and high saturated fat dairy products out of their diet, because this really impacts the inflammatory cascade. So most of the time the endo patient is going to do better on a kind of pesco-ovo vegetarian style diet with high omega-3s and high brassica family vegetables. So the endo patients are the ones I would actually go ahead and give those smoothies to as well, because it really can impact their estrogen metabolism. I'm just going to take a little sip of water. All right. So let's see. I'll answer one more from the pre-populated questions, and then I'll move to your live questions, okay? Let's see. Seasonal allergies. Let's see. Okay, so this is a good one. So how to ovulate with PCOS? Does metformin 1,000 milligrams work, or will we need supplements as well? So this is a great question. So PCOS, or polycystic ovarian syndrome, is another hugely common sort of pathology, female hormone pathology. And in this condition, this condition actually probably should be subclassified into 2 to 3 different conditions, because there's a really wide variety of how it presents. So sometimes if she may not ovulate at all, and so we call that anovulatory PCOS, so the syndrome, polycystic ovarian syndrome. So syndrome is like a collection of symptoms. She may not ovulate, she may have excessive hair growth, she may be prone to obesity and blood glucose disruption, she may be prone to acne, specifically on like lower jaw, chest, and back. We would call that androgenic acne. And so these women have the true sort of syndrome where she's not ovulating and she just doesn't get a period. So in those women, metformin can be considered. Typically metformin, the doses started at 1,000 milligrams, and the doctor may choose to move you up to 1,500. Usually we do that progressively because it can be a bit difficult on the stomach, a bit hard on the stomach. So that would be something that you would have to get prescribed by your medical doctor or by your REI. And, you know, metformin really can help with ovulation because it helps with glucose control. And so what I would say is if your doctor has put you onto metformin to encourage a natural ovulation, then it's very safe to assume that there's a lot of other lifestyle factors, diet specifically. Research shows that if a PCOS patient is anovulatory and overweight, if she can lose just 5% of her body weight, which typically is between 5 to 7 pounds, it's not that much, it can actually trigger her to begin ovulating on her own. And so I would say PCOS patients often take longer to conceive because their ovulatory window is more erratic, and so it's more difficult to predict when she's going to ovulate. So if metformin is in your plan, then we should absolutely be looking at a low glycemic index, high protein, plant carbohydrate based diet for PCOS patients that's really aimed at normalizing insulin output and improving glucose utilization by those cells, because that's what will help to lower the insulin and androgen levels and help her ovulate endogenously and naturally. So metformin really should be combined with lifestyle. And then another common agent that I would use in my patients for PCOS, and it's safe to use with metformin, is something called inositol. So inositol, D-chiroinositol, and myoinositol. They're usually combined in a blend, and the dose is about 4 grams a day, and she would have to take that consistently. But that really does improve regulation of ovulation and maturation of her follicles. PCOS, often they have difficulty maturing the follicles to the point where they're big enough to get them to release. So I would say it's a combination approach for PCOS for sure. Okay, so let's see here. I'm gonna see if I can read some of your questions here. It says, seems like every cycle I get a false surge and then it lowers, right? So what I assume she might be saying there, I get a false surge, meaning she's tracking her ovulation and then it drops out. So she may not be getting a high enough surge, a high enough LH surge to release the egg. And maybe she's not releasing the egg. So, you know, one of the things that we could do in that case is to test, 5 days after she sees that surge with a Prove test or that progesterone test to see if her progesterone levels are above 30. That would convince me that she did ovulate. The other way to do it would be to do a cycle monitor. The best and most direct way to get to these answers is to do what we call a diagnostic cycle monitor at the clinic. Now, it's a little trickier because of the pandemic, but cycle monitoring, when you go in and get blood work and ultrasound on day 3, blood work and ultrasound on day 10, typically blood work and ultrasound on day 21, you're going to see your own hormone cascade, your follicle grow, your endometrial thickness, and it provides us with a ton of information. So if you're not sure if you're ovulating, we're going to need to do some testing because that's a huge prohibitive factor for your conception. Let's see. And don't delay, go get tested, because the sooner you know, the more information you have, and context changes choices. So I know it's scary to get the test done, but get the test done. We need to know, right? We can only steer your treatment in the right direction if we have accurate information on your hormones. And I think that's half the battle. If IVF is scheduled for next month at Trio, what treatments are available without delaying treatment? Yeah, if you have an IVF scheduled next month at Trio, go ahead and see one of our naturopathic doctors. They're going to put you onto an individualized treatment plan, give you dietary information, and you'll be able to literally, contribute to the outcome of your cycle. Even if you can't do the full 3 months, start as soon as you can, right? Because some is better than none, for sure. So just engage as soon as you can. I think there's 12 doctors down there now. We'll be able to see you this week. You can call in. I think you can book online. And if not, email me and I'll find a spot for you. Let's see here. Let me see. I'm just going ahead. I need to get my contacts retested. Okay, that's the false positive one I just saw. Let's see, hold on. Can someone with low AMH and high FSH still conceive naturally? Okay, so anything is possible, number one. Yes, I have seen that. I have seen women with potentially previously elevated FSH and lower end AMH conceive spontaneously. I have absolutely seen that. FSH is a pituitary hormone, follicle stimulating hormone. Typically we want that to be, under 10 to 12 on cycle day 3. If it's over 10, then it is a predictive factor that we have reducing egg quantity, okay? Because it's a feedback loop between ovulatory function and your FSH production. So if your pituitary has to turn up the volume, it means that our ovaries aren't responding as predicted, right? So it is a factor that would make me want to know more. And if then usually if we have a high FSH on day 3, they'll go ahead and test her AMH. And AMH, as I said before, is anti-Müllerian hormone. This is a hormone that's produced by viable active follicles in your ovaries. So when we're in our early 20s, it's as high as it will be because we have the most active viable follicles typically at that age. And as a woman gets older and older, each year you'll typically see the AMH reduce, okay? Now I see a wide spectrum of patients, and so AMH declines naturally with age in every woman, number one. Number two, you can be low for your age, right? And so you need to look at the AMH with respect to your age bracket and your FSH, and then the follicle count on ultrasound. And that gives us the full kind of picture of sort of ovarian reserve. If I had high FSH and low AMH, I would be taking a real think about family planning, and I would be taking a think about how many kids do I want to have. Because sometimes, a woman with elevated FSH and low AMH can conceive her first child naturally, but then sometimes she wants to come back and have another baby. So if you act earlier when we have signals and barometers that are telling us that our ovarian reserve is waning, that's what I would suggest that conversation with that patient kind of rolls out and says, where are we going with your family planning? And, if you are considering doing any type of fertility preservation, because sometimes people do IVF and IVF specifically not to conceive that baby, but have an opportunity to have later babies if they know that their AMH is low for their age. Women with low AMH and modestly high FSH can still respond to treatment. Normally, FSH, they won't start an IVF cycle unless her FSH is below 15. And then I would also say from a preconception perspective, a lot of times you'll see the FSH come down and her ovulation patterns normalize with some good preconception care. So there are different botanicals that I would use, or plant-based agents that are really effective at bringing down that FSH and getting a more ovulatory pattern going. Vitex, wild yam, these are plants that I would normally use to help a patient that has high FSH, low AMH, especially if she was trying to conceive naturally. Let's see. So, are there any supplements to improve egg quality in 40 plus women? Tons. So, the first thing we want to think about in women that are over 40 that are trying to conceive is that we need to actively treat egg quality as well as egg quantity. Once we hit the age of 37, normally we will see the egg quantity decline and also the egg quality. And that can really be, that's part of the reason why we have more chromosomal abnormalities in pregnancies over 40, is because of the egg quality declining after the age of 37. So when patients are trying to conceive either naturally or doing IVF over 40, there's a presumption that there is an egg quality issue. That would be a standard in every clinic. And we would definitely be recommending, your prenatal agents like methylated folate, B12, calcium, essential fatty acids, the basics. And then the egg quality piece of it, the top ones in my mind anyway is coenzyme Q10. I like the CoQ10 that's combined with PQQ. So we use a ubiquinone plus PQQ. It comes in the same capsule, which I love. Normally for a 40-year-old patient, she'd be recommended to take at least 600 milligrams of CoQ10 daily, with PQQ bringing in about 60 milligrams. When you're giving that much CoQ10, you have to give some level of carnitine. Carnitine is an amino acid that takes all of the fat-soluble agents inside the cell where the mitochondria are. So usually I'll give a combination product that has CoQ10, carnitine, vitamin E, and acetylcysteine. Those would be my big ones for egg quality in over 40. Let's see. If I can get one more. So I'm 33 years old. I've been trying for 5 years. I have PCOS and had 3 miscarriages. We are done all of the tests and nothing came back. Okay, so that's a long journey. We see you, and that is really hard. 5 years is a long time. And 3 losses, my patients are exquisitely vulnerable because of the longevity of their treatment course, and because when it's not successful, it can be very traumatic. So for a patient that's 33 years old and has had already been trying for 5 years and had 3 losses, my advice to that patient would be, we need to get her into the hands of an REI, who is a reproductive endocrinologist in infertility, and that specializes in repetitive pregnancy loss. So when a woman has had more than 2 pregnancy losses, 2 or more, she would be considered what we call an RPL patient, or repetitive pregnancy loss patient. And these patients are a very specialized subcategory of patients, and we would be doing a whole layer of testing. So there's genetic testing and karyotyping. There is antiphospholipid testing, blood clotting testing, MTHFR testing. So for this patient, I would want her to be seeing a specialized REI that would be able to monitor all of these tests. And if all of that came back normal, then I would treat both egg and sperm quality under a very kind of, inspection lens. So this is a patient, she's 33 years old. I would want to see what her genetic fingerprint looked like, right? At 33, she's been trying for 5 years. I would say, how come? and what else can we see? If it's not in the blood work, then maybe if we looked into her genetic makeup, we could get a bit of insight into either pregnancy loss or egg quality. So those are the things that I would recommend to that patient. And we do have a specialized RPL clinic at Trio. We're lucky enough to have Dr. Soni Sierra and Dr. Carl Laskin on the Trio team. Dr. Laskin has been running an RPL clinic project called TERM for almost 30 years. He and Dr. Soni Sierra are probably some of the most experienced pregnancy loss REIs in the country. So we have them here at Trio. Let's see, I'll take a couple more questions. Let me see. What about the benefits of acupuncture within fertility treatment? That is a good one. Okay, so we actually do a lot of acupuncture at Conceive downtown, and time and time again, we do see better outcomes when patients are doing acupuncture simultaneously with stimulation. So there's an acupuncture sort of set, if you will, for that. And we would normally start, if she's doing either IUI or IVF stimulation, normally we would start on cycle day 3 when she comes in for her blood work and her initial ultrasound. And at that time, we'd be able to see her hormone levels and how many follicles she has and be able to modify her treatment plan. And so normally I would suggest a patient getting about 3 to 4 acupuncture sessions about, once to twice a week leading up to ovulation. And then normally they'll get acupuncture once a week post-ovulation in the 2-week wait. So that would be when you're in IVF stimulation or retrieval. And if you're an IVF patient that is potentially doing an embryo transfer, what the focus of that acupuncture is really to improve the endometrial lining and to improve the blood flow. So a lot of the acupuncture research does stem surrounding blood flow and reduction of blood flow or blood flow impedance within the uterine artery. And so with blood flow comes, nutrients and oxygenation, supplements that I would give you, expensive fertility drugs that your doctor would give you. So, we all know that IVF patients and fertility patients are highly vulnerable and often highly stressed individuals. So when you're stressed like that, you tend to vasoconstrict and blood flow is diverted away from your reproductive tract. So acupuncture is a really beautiful way of non-pharmaceutically vasodilating your arteries and providing better blood flow. But as a side effect, it has a massive impact on stress reduction, because when we do those acupuncture sessions at my clinic anyway, we often will pair them with cycle day specific meditations for the patient. And so that in combination with the acupuncture itself releasing endorphins and enkephalins, the patient walks out feeling sort of euphoric and a little sedated, which is nice for her, right? So there's a good amount of data. Actually, we have new data coming out of Conceive that I hope to share with you soon, demonstrating that indeed acupuncture has a positive effect on both IVF cycles and embryo transfers and IUI cycles. All right, guys, ladies, let's see. I'll do 2 more, okay? 2 more. Let's see. How do you improve egg health after egg retrieval? We had 2 embryos that were not viable. So this is a situation that I see all the time in the clinic, where patients, come through and do an IVF cycle, and we produce a number of embryos. And sometimes if we genetically test them, they come back genetically abnormal and they're not viable to use. Either that or the embryo will actually arrest and not form a blastocyst and not mature into a mature embryo. And in this case, you know, first of all, it's devastating for the patient to go through that level of treatment and come out sort of without a viable embryo to transfer. So the question, and this is why a lot of people land in my office, is what do I do now? You know, the treatment didn't work. And so really the answer to that is to invest in you and your partner doing preconception care before you would ever try going back for another cycle. The preconception care can often make the difference in egg quality and sperm quality, and improve the embryo viability. So I would suggest doing preconception care before attempting any other treatment. Let's see. Any more? Great. Okay. Let's see if I can find one more. Yeah, Katie? Okay.
Oh, I was gonna say check the chat box on the right.
The chat box on the right. Oh, on Zoom.
Putting them in there. There's a couple more.
Okay. Thanks, Katie. This is my IT tech person. Oh, here we go. Thanks, Katie. I can barely read all of those. Let's see. How to improve egg. What are the benefits of fertility acupuncture? Let's see. 33 years old. Looks good. Okay. I think I got them all. How much? Oh, here's my last one. Okay. How much recommended carnitine for over 40? Okay, so you were listening to me. So earlier I had mentioned that I often use carnitine in my patients when I'm giving them high dose CoQ10, because carnitine is like, I call it the taxi cab that takes all the fat soluble nutrients. So if you're taking a boatload of CoQ10 and fish oil and vitamin D and vitamin E, all of those are fat soluble agents. And they struggle to get across the cellular membrane inside the cell without this taxi cab, the carnitine taxi cab. So carnitine is an amino acid, and you know, a therapeutic dosage of an amino acid starts at about 1,000 milligrams. It's a lot, right? So normally I would say I would dose between like 1 gram to 1.5 grams of carnitine. So most times you'll see me give that in some type of a powder form. Like there's this nifty little product by BioClinic that I like called the mitochondrial formula. And it has CoQ10 and carnitine and glutathione in a little scoop, and you just shake it into a glass of water. It's kind of like an electrolyte. So that's how I usually do it. You'll often see a lot more carnitine in male products, but I always kind of say that like amino acids don't really have a gender. All of us kind of need all of them. Although there is a heavy amount of research on carnitine and sperm quality and sperm motility specifically. So you'll probably see more carnitine in male-based products, but I always give it to my female patients, especially those that are doing IVF. So there you have it. Okay, well, I really want to thank everybody for joining me on this gorgeous Saturday afternoon. You know, here at Conceive, we really want to support this community because we know it's hard, and especially during the pandemic, you know, there are a lot of things that you can do at home to empower and improve your fertility at home during the pandemic. And we're here to help. So if this went over well, then you know, we have 12 other doctors at Conceive, and we'll start doing more of these videos if you do find it helpful. If you want to see more information about a particular topic, ladies, just send it on through, and we will absolutely get that information out to you. So again, my name's Tracy Malone, Dr. Malone from Conceive Health, and we are here to help you in your fertility journey. And we did want to recognize Canadian Infertility Awareness Week, and 1 in 6 is a lot of people, and the conversation needs to be had, and treatment options are available. Clinics do remain open. It's a little more complicated, a little more screening, but we can still get there, right? So if you're thinking about it or you have questions that are unanswered, don't scour the bottom of the internet. Come and talk to a professional that can guide you with your own treatment plan that pertains to you, because everybody's different. It's as individual as your fingerprint. So thanks so much. Enjoy your sunny Saturday, and take good care, folks. Okay. Bye-bye.